thank you again for the invitation to present today. And I was very honored to receive the Mid-Career Award. So thank you for that and for joining. My presentation today, as you said, is about the communication tool and huddles that we did pre-COVID and also what occurred during COVID. So I'll cover that as well. And so just an overview of the webinar, and I'll do my best to keep on time here. I've got some notes. But I'm just going to cover a little bit about reimagining the long-term care sector, some background on effective communication in long-term care. The Huddle study is looking again at that communication tool I'll talk about, and huddles, how we implemented those. Some implications for practice, as well as some next steps, and I'll tell you what I'm up to next based on this work. And I just wanted to provide then some background here, and I know many of you would know this. This is in the context of Ontario, but Ontario has 620 licensed long-term care homes, and ownership varies by province across Canada. But in Ontario, the homes are either public or privately owned. The majority of the privately owned are for-profit organizations. Not all homes are accredited. It's not mandated, but in Ontario, there's about 84% of homes that are accredited. Again, this will vary by province. And the Ontario Long-Term Care Association highlights that wait lists for long-term care beds have doubled over the past 10 years. And currently, there's over 45,000 people waiting for long-term care in Ontario. And Ontario's 80+ population is projected to more than double by 2040. So the demand for long-term care is projected to increase in the next 10 years by an average of 38% in Ontario. So I just wanted to highlight some of those areas, kind of provide some context. As well as staffing, I just wanted to touch on this. Is from the Long-Term Care Association as well. In their 2024 budget submission, they highlight recommendations to increase the workforce and to enable them to work to their full scope of practice. We've been hearing a lot about that lately as well. 80% of residents need support with activities of daily living, and 76% have some form of cognitive impairment. By 2029, the sector will need to more than double its current workforce. And this is from the Ontario Long-Term Care Association, as I mentioned. Some of the statistics coming out during COVID was looking at the turnover of both leadership as well as difficulty filling staffing in their shifts. And I've also pulled some reports here. So some of these are actually pre-COVID. Some of them are lessons learned because of COVID. So there's different reports we've been hearing in the news and reading different provincial, national reports about the long-standing deficiencies in the long-term care sector, in quality and safety care, staffing levels, funding, and oversight. So I've just pulled some here. But there are innovations that are taking place and some promising practices looking more at sustainable solutions. And as many of you know, the government has committed to some substantial funding, as well as increasing the hours of resident care. We've read about the Fixing the Long-Term Care Act, which outlines new regulations to improve staffing and care through accountability and transparency as well to protect residents. As you know, the new National Dementia Strategy was published in 2019, and that focuses on improving the quality of life of residents as well, and those living with dementia and their caregivers. And also, we've been hearing discussions around the Safe Long-Term Care Act. So consultations for that are now closed, and they're looking to table that legislation by the end of the year. So lots more work to be done, but some progress made as well. That is a bright slide. So I just wanted to highlight the research that I'm currently involved in leading. I've been doing research and some of it with Lori Weeks in the past as well. I've been doing research in long-term care for 15 years now. My program of research explores ways to build workforce capacity in long-term care, as well as ways to engage the team and residents and families in care planning, looking at different strategies for that and to focus on person-centered care. So I have 4 studies here. The first one is the one I'll talk about because it's completed, the Huddle study. But I always like to engage residents and family and kind of co-design as well in my research. So the second study there, relational coordination, is looking at how staff across the different work groups coordinate care when a resident has a fall. So it involves an online survey with them. It's also looking at staff and resident outcomes such as well-being. So it's looking at how they coordinate this care across the groups as well as within their teams within nursing and across the groups of PSWs, looking at staff burnout. We're in 7 homes right now. We'll be doing some interviews as well. This is taking place across Ontario. Actually, we're still recruiting for that. If you're interested, you can send me an email. And also, I'm co-leading a study with Dr. Charlene Shu. Some of you might know her from the Faculty of Nursing here at Bloomberg. We're looking at innovating a more inclusive long-term care system. This is an international study with Brazil and Switzerland and the US, looking at developing a framework and tools to assist homes to implement their innovations and looking at inclusivity as well. And I'm just starting a study looking at balancing infection prevention and control measures with person-centered care. This is a pan-Canadian study that will be conducted in 8 provinces. So lots of exciting work on the go here. So focusing on this study that I'll talk about here, the Huddle study, this one we just completed, as I mentioned. This was to assess the feasibility of an intervention to engage long-term care home residents, their family partner, and the team in a collaborative approach to care planning. So we did this in 2 phases. The first one is we developed a communication tool based on SBAR. We adapted that, so I'll tell you about that. And it was for residents and family to use. And then phase 2 was to implement 3 intervention components, which I'll tell you about. And for huddles, staff and team huddles are not new. We've been doing them in acute care hospitals, around patient safety huddles, falls huddles. They've also been done in long-term care. But the unique or difference here was we wanted these to be led by the resident and the family member. So this communication tool was to support and guide that process. So just a note about the team, Kathy McGilton from Bloomberg Nursing and Linda McGill's Hall also on the study as co-investigators, Wendy Duggleby from the University of Alberta, and our partners, Baycrest Center for Learning, Research, and Innovation, the interprofessional educators from there assisted with the study. And I also want to acknowledge our research assistants as well. We had some undergrads and PhD students working on the study as well. So I just want to come back to some background again from the literature, and many of you working long-term care know this as well. Ensuring that residents of long-term care homes and family are meaningfully engaged in collaborative care planning is key for person-centered care. And encouraging family involvement in care can strengthen communication and relationships between families and the care team, which can contribute to residents' well-being. But new models of care and best practices are needed, and research is becoming more focused on what patient engagement looks like in long-term care. So we hear a lot about patient engagement in acute care hospitals, and what does that look like for residents and families in long-term care homes? Because patient engagement is a broad term that includes the healthcare providers, families, and residents as well. So, and there's patient engagement frameworks that guide collaboration and different initiatives as well around patient engagement. So looking at how we can meaningfully engage residents and families in meaningful ways to support their decisions and their own care. So frequent engagement of residents and family members through the huddles would be one way that we could engage them in these meaningful activities. And again, from the literature, the importance of effective communication and building relationships between healthcare providers as well as the family and the residents has shown to improve quality of care. So that's well established, as well as we know there's also breakdowns in communication that occurs, miscommunication, and it can result in some conflict sometimes, which can impact care as well. And in some previous research that I did in some interviews, we found that there was a need for more proactive communication in some of the homes. This was pre-COVID, but uh, oftentimes communication can be reactive, where staff may respond to a family concern. And we're looking to see how maybe huddles can support some proactive communication as well in this structure and process that we created. And that communication tools may be able to support this communication process. So there are calls in the literature for a shift of focus from communication tools that have been developed specifically for healthcare professionals to those specifically for and with patients and families, and in this case, residents. So there have been some communication skills training, but again, a lot of this has been done in acute care, and a lot of the communication tools have been focused on staff communication. So handover, for example, at shifts, and how they can use these tools to communicate information among the teams. So we were looking at developing a tool that could provide some guidance for residents and families themselves. And this slide is one that I borrowed from the Baycrest team, looking at effective communication, how it can support a clear message and knowing the context, which is followed by confirm mutual understanding. So it's looking at how we can share objective information and the benefits of that, and how the communication tool that we developed could support this process. And how during COVID now, especially, how trust between staff and family and the residents really becomes quite key. So that was just some background there. So getting to the tool then, and we haven't published the findings yet from this overall study, but the tool, so far we have published that and our process for feedback on this. So just briefly, we developed a communication tool, again, to be used by residents and the family caregiver dyads to lead a huddle discussion about one aspect of resident care. So it provides them with that structured communication that I just mentioned to share information with teams. So this was before COVID. We conducted in-person interviews with family and residents from 2 long-term care homes for feedback on the tool in terms of its language and content and perceived usability, because they haven't used it yet. We're just developing it. So we developed it with our study partners, which was our interprofessional educators from Baycrest. We consulted a content expert collaborator on our study. And then we took it to the family members in a focus group for their input. And then we revised it and then went to show residents the tool for their input as well and further refined it. And then the huddle participant feedback was after we did the huddles, we could assess the tool. So this was essentially the tool, and we adapted it from, as I said, SBAR. So it has 5 questions that are designed to create this objective, concise narrative for residents and family to speak with staff, and also to specify requests to follow up. So a lot of what we found in my earlier study was the communication was there, but sometimes the information sharing with other staff kind of get lost along the way, like that communication where things get passed on and get lost in translation sometimes. So this is SBAR, but we changed the A, which would have been assessment to action, to make it more action oriented. And we added request so that it had that follow-up plan at the end. So the situation is the experience about an aspect of care. So the resident may want some part of morning care, for example. Some part of that routine changed. The background is sharing the information about the situation. The actions are what has been done so far. And then recommendations, the idea here is that these are developed with the staff and the residents and the family together. And then any requests that they have would be followed up with shortly thereafter with a timeline. And this would all be documented during the huddle. Sorry, that's looking kind of blurry there. So these are the 3 intervention components that I'll just go over, and then we can have some questions here. It's a lot of content. So we had an education day to build staff communication skills. This was using the team essentials for engaging families in care. This was a learning module developed by Baycrest, and it was for nurses, personal support workers, allied providers, and leaders at each site. Leadership coaching sessions using a quality improvement approach to align the huddles with the prioritized goals from the long-term care home so that it was meaningful for them as well. What did they have in their quality improvement plans that the huddles could fulfill for that? And also building leader capacity to support the huddle process. And the huddles were 15-minute discussions. As I said, it was on a care-related topic that were led by the resident family dyad. And then the evaluation were the phone interviews that we had at the end. This was actually our plan that's been revised. We actually had more huddles planned before COVID, but I ended up doing 3. So again, these are our participants. We had directors of care, assistant directors, managers, resident family care coordinators as leaders. Our staff were nurses, PSWs, allied and support service workers as well. Residents who could speak English, but were not severely cognitively impaired, and that was because of the amount of engagement required. And family caregivers, this was pre-COVID, that they were the substitute decision maker and visited at least monthly. So of course that changed with COVID. So the purpose of the huddles then again was to lead a discussion about resident care with staff and to facilitate this proactive communication. So we had them at 15 minutes, just so that the staff, could have that time away from the floor. And it was with 2 or 3 staff that had attended the education session and the huddle coach that attended the leadership coaching and the session that we had as well for the education. So they would come prepared with the topic that they wanted to discuss and using that tool. And this was because we didn't want the resident family spending the 15 minutes deciding what the topic would be. And this was done in a private room at the long-term care home. So there was some setup involved, some structure to it. And so having them decide ahead of time too, that they could pull the staff that they needed for the topic as well. It was aligned with that. So I just want to explain the huddles first for some context, but we actually started with the education session first at each site. And this was to build the communication skills of the staff around engaging families in care using that learning module. And this was before COVID, so it was nice we could do all these in person. So the Baycrest interprofessional educators were great because this was in person, so we could do role playing, video simulations, small group work around some scenarios that were common between staff and family to really build their communication skills. And then they could apply this in the huddles. And there were full days. We targeted 20 staff per home across 4 homes. So these were the communication strategies and competencies that the educators had used. ARC is compassionate communication, so it acknowledges the family experience. So for example, it reassures them through shared goals. The 3 R's are recognize, reflect, and respond. So this is responsive communication. SBAR, as I mentioned, that's the collaborative communication. So it's a relational practice of structuring communication. And then the 8 steps there, engaging families in care, was the learning module that they had. So it encompassed all these other tools as well. So we had 74 staff and 23 leaders attend the education day across 4 sites. So 97 in total, and this was in 2019. So there was training involved. So there was a time commitment involved here and some investment. So members of our team provided in-person training with each resident and family member dyad. So we taught them how to use the huddle tool. We had a video simulation that we were involved in, which took a long time. It took 6 hours to do a 6-minute video for us to record that. Not my forte. And the resident and family members practiced the tool with a practice huddle first, and then they did them. So we had, before COVID, we had 7 family resident dyads do the practice huddle, and some of them went on to do a few huddles as well before COVID. And the leadership coaching. So this was the Baycrest educators helped facilitate this as well. This was done in 1-hour sessions. So we had 2 or 3 sessions at each site during the study. And this is where they selected their quality improvement goal that they wanted to align engaging residents and family in the huddles. And again, they were also trained to be huddle coaches so that they could mentor staff throughout the process and really encourage it and find that 15 minutes for them to partake in that. So this is an example from one of the home that they chose that they wanted to look at increasing resident participation in programs. So they would do this by way of having them engage in the huddles. That was one of their goals. And they also wanted to build relational team skills around effective communication and collaboration. So this was another way they were going to engage staff. So that was their quality improvement plan. So they could use this as some of their goals. And then, of course, like many of us, we had to adapt our intervention that was in person. We were making some good progress there. And we ended up doing it more virtually. So we had to change a lot of our training materials and the way we were doing things. But it was interesting because it was in ways that we never thought possible. When we first wrote this grant, I wasn't planning on doing virtual huddles. Wasn't really talked about at all. So it's nice that we got a chance to actually look at broadening how we can use the tool as well as the huddles. So we developed an e-learning module with the Baycrest team for staff that they could use as a refresher from the education day. Some time has passed now. We had to go through ethics. So this is quite a while later because they were busy with COVID as well. So we let some time pass here before we came back and introduced maybe doing this virtually. And we also had this extended family as well, that they could use an e-learning module to call in when the visitor policies were in place. So they could use the tool to call into the homes to ask about the resident. And then for residents, we ended up training them more virtually with the huddle coach there helping us as part of the team there. And so that's a link to the huddle tools there. We also shared it more broadly with Ontario family caregivers during COVID. The link to the e-learning module included the huddle communication tool, and it was on the Baycrest Cleary website, the Center for Learning, Research and Innovation. And it was distributed more widely through Family Councils of Ontario through their newsletter. So we were in 4 long-term care homes in Ontario, and this allowed us to actually have it more broadly for other family caregivers outside of the study sites during COVID. So we could plan to go back. I did speak to one of the family members using it, but we plan to go back now. We have quite a few, it shows numbers of family that have used it during COVID to call in to the home. So we can go back and evaluate the tool a bit more. So I guess part of it's done with the huddles, but I can go back and look at some of that data too. So it's leading to more research in this area, which is good. So we were able to complete it at one of the study sites. We needed to recruit new resident and families for the huddles. The staff were the same, but so they just did the e-learning module as a refresher. So we had 6 leaders, 3 nurses, and the 3 resident family caregiver dyads complete the study at one of our 4 sites. I say virtual huddles, but they were actually together in a room. This was after the visiting policies were lifted. So they were actually all there. I was joining on Zoom, and occasionally a family member would come on Zoom to do the huddle. So they could be done virtually, but they were all in the room together. So it was kind of a hybrid, I guess. Some of the topics included pain management. They wanted to talk about falls prevention, impact of COVID on social activities, because it was still very fresh in their minds there, and meals and diet were some of the topics they talked about. We did 2 leadership coaching sessions. These were done virtual on Zoom with the leadership team at this one site. to explore how we could integrate huddles going forward at this site. And then we interviewed them. I'll talk to you about some of the feedback we got about that. But just some notes about the leadership coaching. There was a lot of time that passed, several months between that table I first showed you of the example of the leadership coaching ideas that they had around the huddles and improving communication, to having these other two virtual leadership coaching sessions that we did. So several months had passed. So we revisited some of their goals, and these became 1-hour meetings on Zoom. So we talked about that, and a lot of it again was around how we can adapt this process to the home going forward. For each home, it would look a bit different. So what's the structure, the process, the logistics, and the timing that would work there? Again, because it's a study, we had to schedule them for 15 minutes. We had to all be there. So they were somewhat structured, but going forward, they wanted to tie it in more to the practices that they already had going in the home, and maybe it could be more impromptu as well. Like, let's just do a quick huddle about this. So that would be meaningful to them. And so this is some of the feedback we got then. As I said, we did some phone interviews with residents about the usefulness of the huddles and the tools. So again, this was after COVID. So we have 3 residents that we spoke to about it that did the huddles. And they found that they were helpful and that they liked the tool to help guide their discussion around what they wanted to talk about in advance. So they enjoyed it. They said they felt listened to because they were leading the huddle with this tool. So they found that helpful. One resident mentioned that it kind of got off to different topics when, they were to stick to one topic just because of the timing. So they went over their time and ended up talking about more than one topic, but they said it was a process to get used to that. The family had similar comments. They liked the tool because it kind of guided their thinking and their way of prioritizing what they wanted to talk about in advance. And they felt listened to as well. So it helped organize their thoughts. They thought the huddles could be longer, around 20 minutes. So again, the homes would have to see how they could adjust that time with the staff as well on the floor. And they mentioned some of the huddle follow-up that they wanted was a bit delayed because of COVID. So this is when, they were short staffed, but they indicated the topic wasn't urgent. So there was a process in place for the staff to follow up with them. So they liked that, and it had like the time, they would come back and assist with that. And feedback from the leaders and the staff. They were asked similar how they could implement these in practice and if they were useful. So the leadership team wanted to find a way to integrate them into their already existing structures. So resident assessments, how they could integrate these into team rounds, so where the resident and the family would be involved in that more, and how they could integrate maybe into their documentation procedures as well. So they had some ideas around how they could integrate it into what they already do. They also described it as a co-advocacy model where staff and family could advocate for the residents' needs. They talked about how it could build trust with residents and family, and as an informal check-in tool. And a process, as I said, to be combined with existing structures. They also said it was an investment now for future larger conversations that were more proactive. And nurses found that the tool was helpful to better understand residents' needs, and also for them to go back and communicate the residents' needs with the staff and have that information sharing. So they found that helpful as well. So just to wrap up then, some practice implications, again, moving from doing these in person to virtual, I think kind of broadened our way of looking at this and ways that we can test it further. So it can support communication, partnerships, and compassionate care planning. Huddles offer a structured process that can be implemented, as I said, in person and virtually to support engagement of residents and families in care planning. I think residents got really used to tablets and Skyping with their families. So doing some of this on Zoom wasn't too foreign to them either. So they were finding that not too challenging to get used to looking at people on the screen. And the communication tool provides a common language that could improve communication efficiency during care planning conversations. And it could have wider applicability. So I've had questions in the past how it could be used in other healthcare settings. It could be used during flu and other outbreaks. There's still COVID outbreaks, as we know, going on in the homes, or with long distance caregivers, retirement homes. So although they can be considered low tech, as I mentioned, there are some training and requirements and time investment as well upfront. And additional testing of the whole process and tool is needed. So I do have some plans underway to further look at the communication tool, and that's evaluating some of the data that I think we can go back and look at from the e-learning module, as well as going forward how I can look at this and expand this work. So I do have some plans. So this was just announced last week or a few days ago, actually, that I received an AMS fellowship in compassion and artificial intelligence. I'm really looking forward to this. So we're just getting started this next week, but it's looking at compassion and AI to extend some of this work. So AMS is partnered with the Ontario SPORE Support Unit, and they have a strategic priority in compassionate care in a technological world. So their goal is to build capacity of scholars and researchers on the impact of how digital technologies and AI can enable compassionate healthcare. So merging those two worlds together. So building on this work, I wanted to develop a Huddles app or some kind of prototype of the tool and the app that it could be used as a digital mobile application. And then I realized I didn't really know how to do that. So I applied for this fellowship, which was nice because it's a mentorship model. So I have mentors to help me with this work and looking at compassionate care. So looking at therapeutic relationships and communication, they mentioned feeling listened to. So how can we look at this tool to enhance compassionate communication, but also merge it with this prototype app as a digital solution. So looking at how can we build on both and merge them together. So I'm going to do some workshops with key groups, so researchers and engineers in the field, as well as, of course, family and the residents as well. So my mentorship team is, I have 2 mentors in digital health and long-term care, and I have a person living with dementia as a mentor on my team and an ethicist. So I'm really looking forward to their mentorship. And they also look at building leadership capacity in this area as well. So they have the fellowship has residencies. So we have our first one mid-October to build capacity in this area as well, and some leadership, so networking with others in the field. So I'm looking forward to that. So that's how this work, you do the work, the study, and then it kind of leads to more down the road, so how we can keep building on this. So I'm excited to start this. But I think that's all I have. There's my pets who are demonstrating compassion. Look at my dirty floor, but Jasper the Labradoodle and Milo, my ragdoll cat, showing compassion.
That's a lovely picture. They look so much alike.
I know, it's funny because my cat used to be pure white and now he's got some black on him, but they merged together as one animal. It's funny. And they I didn't put them like this. They see the camera and they decide they're going to do this pose. It's fun.
Oh, that's so lovely. That's lovely.
That's their compassion. They love to cuddle. They're always cuddling. Sometimes I can't find the cat. So just to thank my funder for this study, the CHR and the Baycrest partners, who did provide some in-kind funding to target the 20 staff per home that we could do the training. So I appreciate their help as well with this.